Well, I think it's a multifactorial answer. So we're getting better at detecting autism, right? So in the past, we were diagnosing kids at 9 or 10 years of age, right? And now clinicians are able to reliably diagnose kids at 2 to 3 years of age, right? So there's more people. There are pediatricians have autism screeners now. So when you bring in your baby, and over the first couple years of life, you're filling out screeners that are looking for autism symptoms, right? So there's just a lot more awareness around autism. But the rates have increased to now 1 in 36 US children have a diagnosis of autism,
Wow.
which is over 2 years ago, it was 1 in 44. So autism is male biased in prevalence. So you have and again, the studies vary. I mean, it's worth noting that autism is a highly clinically heterogeneous disorder, which means that if you've met one kid with autism, you've met one kid with autism, right? So we have to bear that in mind as we have this conversation. But, different studies show that about for every one girl, there's 3 to 4 boys that are impacted by autism. So there's, differences in the prevalence rate. And also, there's different monitoring sites. So, the way in the US that these data are generated is the CDC has 11 monitoring sites across the country. And so they follow children, and then that's where the prevalence rates come from. And they release new prevalence rates every few years.
Autism is a bioneurological developmental disability that affects 1 out of every 160 children born in America. The prevalence of autism seems to be rising as awareness of the disease is made more public to both the general populations and to pediatricians and general practice physicians. A lifelong developmental disease, autism impacts the way information is processed. It appears that while early intervention makes the symptoms of autism less significant, no treatment can completely alleviate the effects of autism. People with autism have restricted, repetitive stereotype patterns of behaviors, interests, and activities. In most cases, these symptoms appear before the age of 3. Furthermore, in many cases, autism is coupled with other disorders that can create additional symptoms. While many of the signs of autism are known, there is no set description of behaviors that can identify a person with autism. With the growing availability of facts about autism, it is hoped that this disease will be easier to diagnose and treat. When determining whether a particular child has autism, an important diagnostic tool is the susceptibility of an individual to the disorder. With increasing accessibility of knowledge flowing from the internet and psychological journals, parents and physicians are more likely aware of the chances that their children or patients have autism rather than another similar mental disease. Autism is a disease that affects 0.6% of the American population. Although this number has risen in recent years, the gender gap in diagnosis remains the same. Boys are diagnosed with autism 4 times as often as girls. While the disease is more prevalent among males, girls with autism appear to have more severe symptoms and lower intelligence than their autistic male counterparts. Even though gender influences the likelihood of developing this disease, the chances of getting autism are not affected by race, religio, or socioeconomic status. The medieval belief that mental disorders are caused by demons has been abandoned. Instead, it is believed that autism is likely caused by a genetic defect that can occur in any individual in any sector of society. With the knowledge that autism is predominant in boys, but that it does not discriminate in race, religion, or socioeconomic status, parents and physicians can begin to look for and recognize the symptoms of autism. What is autism spectrum disorder? Autism spectrum disorder, ASD, is a neurodevelopmental disorder characterized by deficits in social communication and the presence of restricted interests and repetitive behaviors. 1. In 2013, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, was published, updating the diagnostic criteria for ASD from the previous 4th edition, DSM-4, Table 1, 1.2. In DSM-5, the concept of a spectrum ASD diagnosis was created, combining the DSM-4's separate pervasive developmental disorder, PDD diagnoses, autistic disorder, Asperger's disorder, childhood disintegrative disorder, and pervasive developmental disorder not otherwise specified, PDD-NOS, into one. Rett syndrome is no longer included under ASD and DSM-5, as it is considered a discrete neurological disorder. A separate social pragmatic communication disorder, SPCD, was established for those with disabilities in social communication, but lacking repetitive, restricted behaviors. Additionally, severity level descriptors were added to help categorize the level of support needed by an individual with ASD. This new definition is intended to be more accurate and works toward diagnosing ASD at an earlier age 3. However, studies estimating the potential impact of moving from the DSM to the DSM-5 have predicted a decrease in ASD prevalence, 4.5, and there has been concern that children with a previous PDD-NOS diagnosis would not meet criteria for ASD diagnosis, 5 to 7. There are varying reports estimating the extent of and effects of this change. One study found that with parental report of ASD symptoms alone, the DSM-5 criteria identified 91% of children with clinical DSM-4 PDD diagnoses. However, a systematic review suggests only 50% to 75% of individuals maintain diagnoses, 9, and other studies have also suggested a decreased rate of diagnosis of individuals with ASD under the DSM-5 criteria, 10. Signs and symptoms of autism. In the movie Rain Man, Raymond had many of the characteristic symptoms of a person with autism. Those affected with autism share certain social, communication, motor, and sensory problems that affect behavior in a predictable way. However, not everyone with autism has exactly the same symptoms and deficits. Raymond had many of the classical symptoms such as impaired social interactions and repetitive behaviors, but he was also very gifted with numbers and memorization. People with autism range from gifted to severely impaired. In the more severe cases, acquisition of new knowledge and skills is extremely difficult. In some cases, people with autism have normal to high intelligence. They learn quickly, yet they have trouble communicating, applying what they know in everyday life, and adjusting to social situations. Finally, in an extremely small number of individuals with autism, exceptional skills in a specific area are present. These individuals, like Raymond, are known as autistic savants. Because of this range in ability, there is also a range in the amount of assistance those with autism need. People with autism may eventually live independently or may need supportive living and working environments. The majority of those affected require assistance. 60% of adults with autism continue to need care throughout their lives. While necessary, the aid required by those with autism does not come cheap. The cost of the health and educational services to those affected exceeds $3 billion each year. Autism can have profound effects on those with the disease, as well as on the caregivers, family, and society. Given that the best way to improve the condition of someone with autism is through early intervention, recognition of the signs and symptoms of autism is extremely important. People with autism generally have social, cognitive, and behavioral dysfunction. Communication skills and the ability to relate to people, events, and objects in the environment are impaired. Furthermore, a slow ability to learn and think is characteristic of autism. While not all autistics have the same symptoms, the following is a list of some of the signs someone with autism may show. Behavioral symptoms. Performs repetitive movements such as rocking, spinning, or hand flapping. Develops specific routines or rituals. Becomes disturbed at the slightest change in routines. Moves constantly. May be fascinated by parts of an object, such as the spinning wheels of a toy car. Does not make eye contact when making requests. Speaks with an abnormal tone or rhythm, may use a sing-song voice or robot-like speech. Crying tantrums, extreme distress for no discernible reason, marked physical overactivity or extreme passivity, inappropriate attachment to objects, sustained odd play, inappropriate laughing and giggling, remains fixated on a single item or activity, may sniff or lick toys, physically attack and injure others without provocation, inaccessible as if in a shell, cognitive symptoms, starts talking later than other children, loses previously acquired ability to say words or sentences, can't start a conversation or keep one going, Echolalic may repeat words or phrases verbatim, but doesn't understand how to use them. May be unusually sensitive to light, sound, and touch. Unusual perceptual stimuli, looking through people. Apparent insensitivity to pain. Shows no sensitivity to burns or bruises. May engage in self-mutilations, such as eye gouging. Uneven fine gross motor skills. May not be able to kick a ball, but can stack blocks. No fear of real dangers. Lack of speech or impaired speech. Resists normal teaching methods. Social symptoms. Fails to respond to his or her name. Has poor eye contact. Appears not to hear you at times. Resists cuddling and holding. Appears unaware of others' feelings. Seems to prefer playing alone. Retreats into his or her own world. Difficulty in mixing with other children. Standoffish manner. Acts as if unaware of the coming and going of others. Although the primary symptoms of autism are social, cognitive, and behavioral, many people who have this mental disorder have physical ailments as well. In 30% of children with autism, the following physical problems may also occur: allergies, asthma, epilepsy, digestive disorders, sleeping disorders, attention deficit hyperactivity disorder, diabetes, heavy metal toxicity, and/or seizures. Autism may also be coupled with sensory integration disorder. People with this disorder have trouble processing information from the proprioceptive, visual, vestibular, or auditory and tactile sensory organs. In addition, autism may cause poor balance, poor posture, and chronic pain because of the muscle stiffness and muscle weakness that can accompany this disease. People with autism may have persistent viral infections caused by poor immune functioning. Although it is often thought of as disease that affects the mental state, it is apparent that the disease is not limited to social, behavioral, and cognitive dysfunction. Autism can be very debilitating on all facets of life. In addition to the physical ailments that may accompany autism, there are also several genetic disorders that can be coupled with autism. In 10% of the autistic population, other disorders are present. Some of the common disorders are Fragile X syndrome, the cause of mental retardation, tuberous sclerosis, the cause of tumor growth on the brain, and Tourette's syndrome, the cause of involuntary movements and vocalizations. Other disorders that may appear in conjunction with autism include Angelman syndrome, phenylketonuria, Joubert syndrome, and Mobius syndrome. These disorders may exacerbate the already present symptoms of autism. The chance to live a semi-autonomous life decreases if a person is affected with more than one disorder. While the potential effects of having multiple disorders may be devastating, this information does shed light on the potential causes of autism. Causes of autism. While the exact causes of autism continue to be sought out, the presence of the disease has been known for many years. In 1943, Dr. Leo Kanner of the Johns Hopkins Hospital introduced the label early infantile autism into the English language. Around the same time, Dr. Hans Asperger, a German scientist, described a milder form of early infantile autism that later became known as Asperger syndrome. It was not until many years later that the Diagnostic and Statistical Manual of Mental Disorders reported autism as a disorder. The DSM-4-TR 4th edition, text revision, now lists 5 pervasive developmental disorders that are often referred to as autism spectrum disorders. These pervasive disorders, such as Rett syndrome, childhood disintegrative disorder, and Asperger syndrome, are characterized by varying degrees of impairment in communication skills, social interactions, and restricted, repetitive, and stereotype behaviors. While there has been a developing understanding of the symptoms of the disorder, there has also been an emerging insight into the causes of autism. Years ago, it was believed that autism resulted from bad parent-child interactions. As knowledge about autism has increased, this idea has been replaced with more biological approaches. While genetic defects and brain abnormalities are the commonly accepted causes of autism, the possible adverse side effects of immunizations have received a lot of attention as a cause of autism. The vaccine for measles, mumps, rubella, MMR, has been implicated as a possible cause for autism. Vaccines that contain thimerosal, a preservative that contains a very small amount of mercury, are thought by some to trigger the onset of autism. However, many studies have refuted the claim that vaccines are the culprit. Geneticists and researchers have been able to conclude that genetic defects are the cause of autism from the results of studies completed on families that have an autistic family member. In families with one autistic child, parents have a 1 in 20 chance of having a second child with the disorder, an eightfold increase compared to the general population. Furthermore, relatives of autistic children may show mild impairments in social and communication skills or engage in repetitive behaviors. These family members are not labeled with autism, but they do share some of the characteristic behaviors of a person with autism. Social deficits, language abnormalities, and psychiatric disorders are part of the family history of people with autism. Twin studies have provided more persuasive support to a genetic link. In 1977, Folstein and Rutter demonstrated that there was a higher concordance rate among monozygotic twins than dizygotic twins. Because monozygotic twins A share the same genetic makeup, whereas dizygotic twins B are no more related than siblings, the research points to a genetic cause rather than an environmental cause. With this information, geneticists have tried to understand the method of inheritance of this disorder. The transmission of the disorder from male to male in a number of families rules out the possibility of X linkage as the prevailing mode of inheritance. Despite theories on the mode of inheritance, the gene or genes responsible for autism have not been precisely located. Thus, autism is believed to be polygenic. Many genes have been suggested for their functional role, location within a candidate chromosome, and positive association with the disease, but replications are elusive. It is likely that multiple genes are interacting with one or more environmental factors to produce autism. Thus, merely having the genetic code for autism does not guarantee that it will develop. Data collected from whole genome screening in multiplex families, families with greater than one affected family member, suggests that autism is caused by the interactions of at least 10 genes. Pinpointing the genetic source is difficult because environmental cues may be involved and because the exact clinical phenotypes of autism remain elusive. There is not an exact description of how a person with autism behaves or thinks. This variation in phenotype makes it difficult to find the exact genotype involved. However, this has not stopped researchers from trying to locate the genes involved in autism. By comparing the genomes of those affected by autism, the possible gene loci responsible for causing autism may be found. The most consistently replicated linkage findings have been on chromosomes. The putative speech and language region has been implicated in autism. This could explain why children with autism have difficulty in learning and maintaining a vocabulary. Chromosome 15 duplications have been suggested as culprits in the search for the cause of autism. The GABA-A receptor subunit and UBE3A genes on chromosome, as well as the oxytocin receptor, have variant alleles more often in the autistic population than in the non-autistic population. Furthermore, variant alleles of the serotonin transporter gene, 5-HTT on chromosome, have been pinpointed as possible causes. The genes FOXP2, RAL/ST7, IMMP2L, RELN, and locus have also shown to be abnormal in those with autism. The extensive number of implicated genes shows the complexity of the genetic causes behind autism. With the knowledge that autism is polygenic, researchers are slowly learning what interactions between genes and the environment can cause autism. It appears that certain environmental cues can trigger the onset of autism. The prenatal environment can greatly affect whether a child with a specific genetic composition will acquire autism. In one case-control study by Dakin and McMahon, maternal reports and medical records of illness during pregnancy showed relative risks of 4.1 for influenza and 3.3 for rubella. Chess et al., 1978, examined a cohort of about 250 children with congenital rubella and found that 7% were later diagnosed with autism. Rubella may play a large role in causing autism, according to Dakin, McMoho, and Chess et al. In a different epidemiology study by Holtman et al., 2002, a link between daily maternal smoking during early pregnancy and autism was reported. Further studies have not replicated the findings. Therefore, other factors may have confounded his results. In studies by Rodier and Hyman, 1998, a link between autism and early in utero exposure to thalidomide at the time of neural tube closure in the fourth or fifth week of gestation was discovered. Gestational exposure to valproic acid, as well as maternal infections of cytomegalovirus, measles, mumps, or herpes, may account for a small number of autism cases. The prenatal environment, depending on the conditions, plays a huge role in triggering autism. It has also been found that toxic exposure and teratogens in the environment may be linked to a small number of autism cases. Microbial and chemical substances appear to play a prominent role in initiating autism. Thus, though genetic defects are largely involved, environmental cues contribute to the onset of this disorder. When the disorder begins to manifest itself, brain abnormalities appear in those affected. These brain abnormalities often occur before 30 weeks of gestation. In fact, it appears that abnormal cell migration between the third and fifth months of gestation can lead to cerebellar abnormalities recognized in people with autism. Furthermore, a possible sudden, rapid head growth during infancy may be an early warning sign that autism is developing. The amygdala, hippocampus, and corpus callosum are the regions of the brain that appear to be most affected during the development of autism. Another major brain region, the cerebral cortex, seems to have disorganized columns in persons affected with autism. While the brain structures of people with autism are altered, so are the individual neurons that make up these structures. For example, the distribution of neuropeptide and neurotrophin at birth is altered in children who later develop autism. Furthermore, children with autism have a dysfunctional myelination process. To explain these brain abnormalities, the growth dysregulation hypothesis has been introduced. According to the hypothesis, anatomical abnormalities are caused by genetic defects in brain growth factors. Knowing which areas of the brain are affected may help researchers discover what genes are responsible for autism. Autism does not stop its effects in the brain. The immune system of people with this disorder seems to be affected as well. Many neural immunomodulatory factors differ in individuals with or without autism. The profile of cytokines, activation of leukocytes, and other immunological parameters are dissimilar in persons with autism. Children with autism have 20% more B cells and 40% more natural killer cells than children without autism. In a study by Dr. Judy van der Water, the immune cells of children with and without autism were mixed with toxins and bacteria. In response to bacteria, cytokines, or the immune signaling proteins, were produced in lower levels in the group with autism, but the two groups did not react differently to toxins. The low level of cytokine production in response to bacteria is deleterious to persons with autism and may account for the poor immune functioning of people with this disorder. Research into the different immunological cellular components of people with autism is hoped to create a diagnostic blood test that can identify people with autism. With an early diagnosis, intervention and treatment can begin for people with autism. Treatment of autism. Autism, while it can be treated, has no cure. However, when begun at an early age, treatment has proven to be very effective in reducing the symptoms of autism. The goal of treatment is to teach skills and behaviors that will allow autistics to function within the confines of the disorder. The treatment for autism is multifaceted because this disorder has both biological and behavioral components. Autism spectrum treatments. For many people with autism, a regimen of vitamins and medication, as well as multiple therapies, are employed to reduce the symptoms of autism. With early treatment, many autistics have higher functioning and can also learn skills that will help them cope with the disorder. In many children with autism, intervention is begun early so that they can begin to improve behavioral and social skills. In some cases, children with autism are placed in highly structured education programs with a team of specialists. In these programs, children are offered a variety of activities and therapies. Physical therapy is implemented to improve motor skills, coordination, and balance. Occupational therapy is used to introduce and improve age-appropriate self-help and coping skills in order to give children with autism a better meaning of life. Speech and communication therapies improve language skills and vocabulary of children with autism. Music therapy promotes communication, relationships, learning, mobilization, expression, and organization, while stimulating many areas of the brains. Sound therapy, much like music therapy, can improve a child's ability to communicate, recognize frequencies, maintain eye contact, and respond to others. Vision therapy helps children integrate peripheral and central vision processing, improve perceptual ability, and increase attention span. Animal therapy helps to develop a child's motor skills and emotional relationships. Recreational therapy builds social and motor skills in children with autism. All therapies work to decreases a child's hypersensitivity to touch or sound and improve sensory integration. These programs teach children how to cope with autism, and they provide skills necessary for social interactions. Along with therapeutic treatments, many children with autism begin behavioral modification programs designed to change the autistic behaviors considered abnormal by society. The behavioral modification programs available include, but are not limited to, LOVAS, ABA, TIACH, and Sunrise. Each of these programs attempts to perfect certain skills and reduce problem behavior through learning techniques. Love AAS is an intervention that takes place at home by shaping behavior through reinforcement of successive approximations, prompting and fading procedures, and use of positive reinforcers, being a praise, playing with a favorite toy, small bites of food, that are child-specific and functional. Reduction of inappropriate behaviors occurs through teaching alternate, more socially acceptable forms of communicating the same needs. The ABA method attempts to improve life quality by enabling autistics to live regular lives in natural settings with valued participation in the community. The TIACH Behavioral Management Program teaches children self-care skills in a modified environment using the children's affinity for routines and rituals to reinforce behavior. This method is recommended for low-functioning autistic children because prepares the child for some degree of lifelong institutional involvement. Finally, the Sunrise method implements effective education techniques that jumpstart speech and language development, promote formation of warm relationships, move through challenging behavior, e.g. tantrums or hitting, and enable children to move beyond repetitive behaviors. Although each of these methods varies in how it is applied, each attempts to teach people with autism new skills that will help them in their everyday lives. Another aspect of autism that is separate from behavioral therapies and modification programs is the biological component of autism. Special diets and medications have been shown to improve the symptoms of autism. One such diet is the gluten-free/casein-free diet. This diet entails removing all wheat protein, gluten, and all milk protein, casein, from the child's meals. The byproducts of these proteins have been found in the urine of children with autism, so it is possible that children with autism cannot process these proteins. It has also been found that adding certain vitamins and supplements to the diet of a person with autism improves symptoms. Megadoses of vitamin B6 and DMG or TMG may improve certain biochemical imbalances and improve sensory deficiencies. For example, addition of DMG supplements to the diet has indicated improvements in the areas of speech, eye contact, social behavior, and attention span. Vitamin B6, on the other hand, seems to control hyperactivity. While certain diets and vitamin supplement therapies improve the symptoms of some children, these treatments are very child-specific. While these nutritional regimens help some people with autism, others do not respond well. However, if this treatment does work, people with autism have greatly improved symptoms when the diet is paired with therapy. Medication, like vitamins and minerals, can improve the symptoms of autism. The symptoms treated by medications are generally secondary symptoms of autism, such as seizures and depression. The clinical symptoms may vary with different chronological ages. For example, a child with hyperactivity or irritability may later develop symptoms of depression or obsessive-compulsive disorder. As behaviors vary, the medications may also change, but the reason for psychotherapeutic medication remains the same. Certain drugs are prescribed to eliminate the psychiatric or behavioral symptoms that are interfering with the individual's ability to participate in educational, social, work, and family systems, as well as to enhance the positive response to other forms of intervention in persons with autism. Many of these drugs tend to have side effects that are worse than the initial symptoms. For example, drugs such as nadolol, Ritalin and lithium can cause abdominal cramping. If bad side effects do occur, other medications are considered until the best alternative is found. However, in many cases, medications can greatly improve the quality of life of someone with autism. In the nearly 65 years since autism has been named, quite a bit of information has been gathered on what defines autism, what causes autism, and how best to treat autism. This bio-neurological developmental disorder influences cognitive functioning and behavioral patterns. Many people with autism have similar behaviors and crippled social interactions. These symptoms are likely caused by a set of genes that are defective. The onset of symptoms can be triggered by certain environmental factors, usually during the time that the individual is in utero. As the disorder begins to manifest, brain abnormalities and other disorders may begin to appear. However, treatments such as therapy, behavioral modification, vitamin supplement therapy, and medication can greatly improve the symptoms of autism. The future treatment options for autism are expanding. When a specific autistic phenotype can be established, perhaps the exact genotype of autism can be discovered. When this occurs, treatment may improve by leaps and bounds. Modern view of autism. In a seminal paper describing the first 11 cases of autism, Kenner pointed to the innate disturbance of affective contact occurring in the infancy of these children and to unusual personality traits in their parents. These observations could have indicated genetic mechanisms underlying the syndrome. However, the predominance of psychoanalytical theories and the particular focus on maternal deprivation in post-World War II child psychiatry led to misconceptions of autism as an infant's response to early disturbances of the mother-child relationship, termed the refrigerator mother. The word autism was first used by Bleuler to index a cardinal sign of schizophrenia, and its use to describe the syndrome unfortunately led to 30 years of controversy about the validity of autism as a distinct syndrome, vis error, vis adult psychoses. The subsequent period of confused terminology, for example, infantile schizophrenia, early childhood psychosis, and symbiotic psychosis, largely reflected untested psychoanalytical models and prevailed up to the late 1960s. Then systematic empirical investigations progressively helped to establish the validity of autism as a separate syndrome. First, the syndrome's strong association with seizures and mental retardation was recognized, as were unusual psychometric profiles differing from those seen among individuals with mental retardation but without autism, and it became obvious that autism is a disorder of brain development. Second, the first adult outcome studies showed that autism is a lifelong handicap, and that despite important gains made by some individuals, long-term, especially social deficits persist, even in the minority of subjects, 10%, who achieve the best outcomes. Third, comparative studies showed that autism is separate from childhood schizophrenia and differs from it in response to treatment, in family history, in longitudinal outcomes, and in a range of associated clinical features, for example, association with mental retardation, sex ratio, and core symptoms. Similar studies also help to differentiate autism from language disorders and other developmental disorders. Autism appeared to involve communication impairments rather than language impairments only. Moreover, concurrent social and behavioral deficits could not be explained solely on the basis of language and communication problems. Fourth, controlled studies of parenting styles and behaviors in families with children suffering from autism indicated that parents of such children were no different from other parents. It also became increasingly evident that autism differed from syndrome seen in children raised in institutions or suffering from maternal deprivation, that is, attachment disorders. Unlike these other syndromes, autism was observed to be remarkably stable across rearing contexts, and no evidence ever emerged to document benefits from the sad practice of removing children from their families to provide them with compensatory therapeutic milieu experiences. Finally, in the early 1970s, experimental studies showed that developmental gains could be achieved in children with autism when they were educated with active rather than passive techniques, when the home and classroom environments were structured to capitalize on their strengths and compensate their deficits, when the educational environment offered a high teacher-pupil ratio and addressed the multiple deficits across developmental areas with individualized educational plans. and when parents acted as co-therapists to promote the generalization of learning in these children. The Treatment and Education of Autistic and Communication as Handicapped Children, TECH program, was developed by Shopler in the early 1970s. This approach to autism became particularly influential worldwide and progressively replaced obsolete, unstructured, psychoanalytically based approaches to the treatment of autism. Conceptual clarification and the availability of new diagnostic tools made it possible to research the causes of autism. The first British twin study, published in the late 1970s, documented substantial differences between monozygotic and dizygotic concordance rates and pointed to genetic contributions to autism. Current heritability estimates for autism are above 90%, which makes autism a strongly genetic disorder. In addition, it was observed that monozygotic co-twins, discordant for autism, often displayed subtle developmental abnormalities involving language, social interactions, and patterns of behaviors and interests. This suggested the family transmission not only of narrowly defined autism, but also of a broader phenotype comprising developmental abnormalities conceptually similar to those seen in autism, but associated with milder impairments. This broad phenotype of autism was subsequently validated in various family studies and is still the object of much research. The concept of a lesser variant of autism, together with the recognition of autism in children with normal intelligence, that is, high-functioning autism and Asperger disorder, progressively shifted our conceptualization toward a more dimensional view of autism spectrum disorders. In the mid-1990s, strong evidence for genetic factors in autism, the development of reliable and valid diagnostic tools, and technological progress in molecular genetics led to molecular genetic studies of autism. Because there are few consistently identified biological abnormalities in autism, and consequently few candidate genes, most investigators have relied on affected relative pairs designs. Several groups are now actively working to identify genes involved in liability to autism. The first molecular genetic findings were published in 1998. Since then, published results from several molecular genetic investigations point to particular areas on some chromosomes, especially chromosomes 2 and 7, as likely to harbor autism susceptibility genes. World laboratories are currently working night and day on these investigations. Epidemiologic research has also accelerated in the last 15 years, 10, and new surveys focusing on a broader case definition of pervasive developmental disorder, PDD, of which autism is only a single form, indicate that prevalence estimates are much higher than previously thought, 60 per 10,000, C11. Debate continues as to whether the evidence indicates that the incidence of autism has truly increased over time, once other explanations for increased prevalence estimates are controlled for example, when the broadened concept and diagnostic criteria, as well as improved case identification, are considered. 12. Increased incidence would be consistent with environmental risk factors having an etiological role, either acting alone or interacting with susceptibility genes. However, no single environmental risk factor has yet been shown to substantially increase the risk of autism, despite claims that the measles virus included in the measles, mumps, and rubella, MMR, immunization given to children at the beginning of their second year may be involved, or that the mercury thimerosal used to stabilize vaccine preparations may raise the risk of autism. Other investigations are currently exploring further the contribution of environmental risk exposures to the development of autism. While the search for genetic and environmental causes is underway, it is obvious that research findings will not translate into practical help for some time. Therefore, it is important to maintain a strong research focus on devising and assessing interventions that promote normal development in children with autism to improve the long-term outcome for children suffering from this devastating disorder. In the late 1980s, researchers investigated the efficacy for very young children of early intensive educational programs based on applied behavioral analysis (ABA) principles. The results showed that substantial cognitive and language gains could be achieved and maintained at follow-up. Initial claims of a cure were most certainly exaggerated, but in the last decade, many other studies have shown similar developmental benefits from intensive early interventions that often share the same behavioral techniques, although treatment programs may be packaged in diverse ways with respect to their particular ingredients and mode of delivery. Recently released expert recommendations, based on state-of-the-art knowledge, propose a minimum of 25 hours weekly of intensive educational interventions for preschool children with autism. In Canada and elsewhere, many young children with a PDD unfortunately still receive much lower levels of service in terms of both quantity and quality. Advocacy for subjects with autism has been required to influence social policies toward this developmental disorder, and efficient associations incorporating both professionals and parents have formed everywhere. One example is the Canadian Autism Intervention Research Network, CAIRN, which aims to improve services for Canadian children suffering from autism. Research into the causes and treatment of autism spectrum disorders is fast expanding. In 1997, with a budget of $42 million, the U.S. National Institute of Child Health and Human Development, NICHD, started a 5-year international network of 10 collaborative programs of excellence in autism, CPEA, to unravel the disorder's mysteries. The network resulted from a congressionally mandated conference that took place in April 1995 to identify gaps in our knowledge of autism and directions for future research. 18. The CPEA network is now in its second cycle of funding. In the last year, another initiative from the National Institutes of Health, NIH, led to the funding, $65 million over 5 years, of 8 new studies to advance autism research and treatment START centers. There is no medical test that can be done to diagnose ASD, weaknesses to ensure the right planning for supports and intervention. There will usually be a combination of tests done directly with the FEO or an ASD. Most of these tests are known as standardized or used to help the team understand an individual's strengths and help the clinical team rule out other disorders that may look like report or input from teachers, caregivers, employers. Both types snapshot, as well as a history of any behaviors they may not get to. Information, direct and indirect, are important for making an ASD or that often go along with ASD like ADHD. Some tests are to interact with an individual while looking for assessments that should be completed as part of an evaluation diagnosis. This helps the clinical team to get a good behavioral, including blood tests or brain imaging. But there are some very specific types of behavior patterns. Other assessments, individual being assessed, as well as interviews that rely on parent-validated tests. They require a well-trained person, a doctor, or observed during appointments. Let's study the biology of autism and the role of oxytocin. Oxytocin and vasopressin are amino acids that have been highly evolutionarily conserved. Pretty much every mammal makes oxytocin and vasopressin. They are structurally very similar and both bind to the same receptors, so it can be difficult to tease out their independent role. The action happens in the hypothalamus where they're made. Oxytocin, involved in uterine contractions and milk letdown, though the role is broader. Bonding in partners used to be thought of as a female hormone. Vasopressin, involved in urinary output regulation and blood pressure. Oxytocin bonds mothers and infants. The passage of the baby out of the vaginal canal triggers the release of oxytocin, lactation does also. Being social is one of the core characteristics of our species. Many disorders are disorders because of a lack of social connectedness. This applies to autism, drug abuse, depressive anxiety disorders. Oxytocin has a pro-social effect. There is evidence that oxytocin inhibits the amygdala's response to fearful stimuli. Social features of autism. Some are socially avoidant, some are active but odd, some could be socially anxious, some want to be social but have sensory difficulty. Again, highly variable. Potential therapeutic use of oxytocin for autism. The lower your blood oxytocin levels, the greater your social difficulty, with or without autism. Some go through behavioral therapy, some even outgrow their autism, but this is rare. There are 2 antipsychotic drugs used off-label to treat autism. Intranasal oxytocin, given in males with high-functioning autism, had potential therapeutic benefit. This is not on the market and does need to be approved by a physician. In a double-blind, randomized control oxytocin treatment administered over 4 weeks benefited individuals who had otherwise low levels of oxytocin. There was no real benefit in individuals with normal oxytocin. There is a lot of controversy as to whether oxytocin is a beneficial treatment for autism. There are very rigid protocols for storing and administering oxytocin. Timing of oxytocin may have an impact on effectiveness. Once you have a negative trial result, funding is difficult to come by. Age may play a role in the effectiveness of oxytocin. No biomarkers. Autism diagnosis is not easily scalable. Interviews with parents can take hours. Clinicians are not all trained to diagnose. We need a quick way to diagnose autism, but there just isn't one currently. It's worth noting that the age of diagnosis is higher in lower income areas. Negative effects of oxytocin administration is that physicians may not recognize the benefit and therefore not write a prescription. Now let's conclude with Huberman's podcast with Karen, and then we draw the curtain.
So autism is a behavioral diagnosis, right? So unlike other areas of medicine where you might be able to take a blood test or there's other sort of tools, it's all a behavioral diagnosis by an expert. So usually a psychiatrist or a psychologist. And they look for two core features. So this is based on the DSM-5, and the two core features are pervasive social interaction challenges and the presence of restricted repetitive behavior. But there are a lot of people with autism who have anxiety. There are a lot of people with sensory challenges. There are a lot of people with seizure disorders, sleep disorders. So again, it's each person with autism has this sort of unique collection of traits, and that's how they get diagnosed.
We're going to talk a lot today about interventions, but how early are some of the behavioral interventions? And I should just say, any interventions introduced nowadays. So if someone brings their child to the pediatrician and they take one of these tests and that child is deemed as having autism, will the 1-year-old or the 2-year-old immediately go into behavioral interventions?
Well, so usually you need to have the diagnosis of autism, and then there are behavioral interventions or a variety of different ones that are used. There are some studies where because autism is highly heritable, you can have one child with autism, and then if you have subsequent children, you're at an increased risk of having subsequent children with autism. And these are called baby sibling studies. So what you're doing is enriching the population of infants that you follow prospectively who are more likely to receive an autism diagnosis. And there are studies where some of those children are enrolled in behavioral studies, even when they're quote unquote at risk.
I've heard before that, parents in which one or typically both parents are, say, of the engineering, mathy, physics, quote unquote, hard science type are more likely to have autistic children. Is that true? I mean, did that bear out in the data? If you look at profession or undergraduate major, does any of that correlate with the probability of having an autistic child?
Yeah, well, what I can say is that there's been some studies. So what we know is that autistic traits are continuously distributed across the general population. And there was a study, and there's a couple different instruments that are used to be able to measure these autistic traits. So there's something called the social responsiveness scale, and then that's a US-based instrument, and there's an autism quotient that's a similar measure that was designed in England. And what we know from work with the AQ is that individuals that are in intense STEM fields like engineering, physics, and math have a greater burden of autistic traits, even if they don't have an autism diagnosis.
Okay, so that leads me to wonder whether or not this whole business of a spectrum is actually multiple spectrums. Is it spectrums or spectri? Someone will put it in the comments on YouTube. We know that for sure. Please let me know. I would like to know. What is the plural of spectrum? Spectrums? Because when we hear the word spectrum, we think, okay, there's a spectrum of severity, right? And in fact, I have some experience with severe autism, not in my family, but where I went to undergraduate university, UC Santa Barbara. Down the way from that school was the Devereaux School, which was a school which has been there for a long time, that parents would send their kids if they were, quote unquote, severely autistic. It was actually where Dustin Hoffman went to study for his role in Rain Man.
Yeah.
And the kids, who were really delightful, they used to come into town every once in a while to the coffee shop where I'd study. And they would also continue on from there to Kmart, which is why the Dustin Hoffman character would say, got to go to Kmart, got to go to, he would do that repetition. Right. That Kmart was down the road from our college housing and the Devereaux School. Those kids were literally in a away from home facility full time. And I spoke to some of the parents at one point, and they were at that facility, meaning the parents had sent their children away to live there full time. Of course, they'd get visits, and they'd get visits home because they were, I suppose we could say, at the far end of some spectrum that made it, at least to the parents' idea, impossible for them to be at home. Okay, now at the other end of the spectrum, if one is just simply thinking in terms of severity, I know people who have self-identified as autistic. That's how they've referred to it. So I feel comfortable saying that they've said, I am autistic. Yeah. And they seem pretty high functioning, meaning they have driver's licenses, drive cars, are in healthy relationships, and manage life apparently well. They have some traits that, yes, I would agree, are a little bit different, right? So this is where we get into neurodivergence.
Right.
But I guess the point is, should we think about autism as on a spectrum, or given the fact that there are these kind of collections of different traits, could there be a spectrum of severity, also a spectrum of, more stereotype behaviors, another spectrum that intersects with that has to do with, obsession with a particular topic. You could imagine that there are, 50 or 60 different spectra or spectrums. Yeah. I still don't know which one to say. And that when we talk about the spectrum, we're really talking about something that's in multiple dimensions and not just one line that goes from severe to mild. Does that make sense?
Yeah, I mean, I think this is where understanding the biological basis of behavior would then allow us to be able to say, here's these different dimensions, right? But not understanding the biology, you're left with, okay, are we lumpers or splitters? Like, how do we think about this? Because autism is highly heritable, so there's about 40 to 80% of autism is genetic, right? So these vary wildly, right? But the common thinking is that the majority, about 50% of autism is associated with common genetic variants. And so the way that we've always thought about this is that there is this, autism is largely an inherited polygenic condition. But what I mean by that is that you have a lot of common variants that are additive. And so if you think about this collection of common genetic variants that underlie this spectrum, right? So if you have less of a dosing of some of these common variants, you might see somebody who's who's higher functioning, like you said. And if you end up with one of these single gene, highly penetrant disorders, you might see severe intellectual disability and sort of lower functioning on the other end of the spectrum. But I think that there is a lot that we don't know. And what you're bringing up, I think, underlines, sort of an issue with autism, which is common for many brain disorders, which is like, if you don't understand the underlying biological basis, it also gets very difficult to diagnose and treat, right? And that's where we are with a lot of different, psychiatric and neurodevelopmental disorders.
To date, has there been any specific neural network that we can point to and say, that's the neural network that seems to be different in people who are on the autism spectrum? I saw a study published recently that seemed to point to the idea that the genes that are altered in autism at least include a large number of genes that are altered, or the proteins that are the consequence of those genes are altered and exist at the synapse, at the connections between neurons. And I'm asking it that way because some years ago, I was at a talk on autism at Stanford, and someone raised their hand and says, do we even know that autism is a brain issue, right? Couldn't it be an issue of, the immune system or the cardiovascular system, which at the time seemed like, okay, gosh, of course it's, but wait, then you stop and you think, that's a really good question.
Right.
How do we know it's a challenge of the brain?
Right. I think that's a great question, right? And there may be, people talk about autisms, right? And so when you think about where the major player is, we're at the infancy of thinking about this, right? And so maybe for some people, it's more of a brain-based disorder. Maybe for some people, it's, the connection with the gut and the brain, right? I think what's also really tricky, right? So one thing that you have to ask is, what are the barriers to progress in understanding autism, right? And so the way I think about this is that let's just take for a moment that this is a brain disorder. How do you study it in people, right? So, it's very difficult to get access to either cerebral spinal fluid, which is a fluid that bathes the brain, brain tissue biopsies. It's very hard to get people, especially children that are really impacted, into a brain scanner, right? Because they can't sit still. They may have sensory issues. They don't want to go into a scanner, right? So a lot of the tools that neuroscientists or psychiatrists have to think about looking at the brain are limited, right? And then the other part is, how do you model? So the other way we might think about getting access or thinking about model systems. What we need to do is think about the control animals, and we need to make sure that the species that we're modeling them in has features of control humans, if you will. So we need to have complex cognitive abilities. We need to have complex social skills. We need to have an organism that has vision as its primary sensory modality, right? Potentially sleep consolidating. So we need to think about all of those. And the tricky part, I think, until fairly recently, was that we were doing all of this work in mouse models. And, the control mice just fundamentally lack many of the characteristics that are needed to model, autism with fidelity, right? And I think that's, when we look at drug development pipelines, about 50% of preclinical failures, so that would be something that's tested in an animal that works and then fails in a human clinical drug trial, 50% of those failures can be attributed to poorly selected animal models. And so I think part of where we will be getting traction is picking, developing sophisticated models as a sort of point of entry into being able to understand some of these things that are really difficult to study in people.
Yeah, it's such a key point. And for those that have not heard of preclinical models are non-human models. So it could be mouse, could be non-human primate, could be flies or worms for that matter. But we're going to talk a lot about non-human primate preclinical models and the work that you've been doing, and of course also the work that you've been doing in humans, the other animal.
Yeah. The other primate.
The other primate, right, exactly. I love to remind people that we're primates, old world primates. So thank you for doing that. So you've been talking about the genetic influences on autism. And of course, genes and the environment interact, right? It's never nature or nurture. It's always an interaction. And that isn't just about the epigenome. It's also just about the fact that nature impacts the genome and our genome impacts the way that we interact with the environment, et cetera. So what is the role of the environment in autism, both the frequency and the presentation of autism?
Right. So, there are, again, lots of different epidemiological studies. So advanced parental age, prematurity, severe prematurity is a risk factor for autism, maternal illness during pregnancy. So there's a bunch of different things that have been associated with an increased risk for autism.
In terms of environmental influences and how they can intersect with biology, one of the things that I was really struck by in the early 2000s that, at least by my read of the literature, hasn't really gone anywhere, was this idea that was proposed by Pashko Rakesh, who used to run the neurobiology department at Yale, expert in brain neuroanatomy in non-human primates and in humans, embryology, really a luminary of our field. And he had a series of papers exploring how the migration of neurons during early development, as you and I both know, but most people out there probably don't know because we haven't covered this in the podcast. It's not typical dinner table conversation. When a human embryo is developing, the neurons are born at one location and they migrate out some distance to their final resting place, where then they grow out their connections and connect with one another. And that process of neuronal migration is so critical for the eventual wiring of the brain. And Rakesh had this idea that perhaps, and I really want to emphasize perhaps, that the more frequent incidence of autism might be correlated with the increase in early prenatal ultrasound. And he had these papers published in a number of really high-profile journals, including Proceedings of the National Academy and Science and elsewhere, showing that in a mouse model, if you do ultrasound, with each successive ultrasound, you got more migration errors, right? So there's, to me, was an interesting example of the environment, frequency of ultrasound and cell migration having some sort of interaction, but it seemed like it never went anywhere. It never got tacked to, okay, you should keep in mind the number of ultrasounds that you're getting for your child. And of course, ultrasounds are critical for pregnant women to get because they can stave off a number of developmental issues, and they're super important. But we've heard about ultrasound, within the scientific literature, and then occasionally we'll hear other theories about, okay, it's having two parents who are both engineers, and then we'll hear, oh, it's toxicity in the food environment. We've heard, hypotheses about vaccines or the adjuvants that the vaccines are contained in. In that large cloud of theories, has anything really emerged from them? It's like, okay, there really seems to be at least one major risk factor, environmental risk factor, because I feel like all those theories come up, get some popular press, a bunch of papers are published. Sometimes those papers are retracted, like in the case of the vaccines.
Right.
And then the theory kind of dies.
Yeah.
So is there any specific environmental influence on autism that we can say, yes, there really seems to be something there?
Yeah, I mean, it's a really spectacularly good question. I think the tricky part about it is that every single person that comes into a trial has a different genetic background, right? And so until we can have these a priori stratified trials where you could then, as a good scientist, you would only manipulate maybe 1-2 variables at a time, right? But when you're doing these large epidemiological studies, because it's very difficult to do experimental studies, right, especially with developing children, I think that's an incredibly difficult study to do, right? So there's been an interest in this field of there's these neurogenetic syndromes that have high penetrance for autism, which basically means that you could have a disorder or, another genetic condition, let's say. It doesn't have to be a single gene, but that a lot of those kids tend to also get an autism diagnosis. And so there's been work in, for instance, Fragile X is a good example, where because autism is so diverse in terms of clinical presentation, that let's say you have a medication that could work for a handful of kids in the trial, you may not be statistically powered to see it, right? So the way I think about the autism world is there's so little we don't know. So think about being in a dark room and you have a flashlight and you only see where you shine the light, right? And so if you think about a very genetically heterogeneous study, it's going to be very difficult to tease out these pieces because an environmental risk factor might be a driver for one kid, but not another, right? And so I think what we need to do is to have these genetically defined subgroups of individuals and then be able to test the gene by environment interactions, or in this genetically defined group of individuals, can we test this certain medication to see if it's beneficial for this subgroup of children?